Hello, my name is Dr. Stephen Prakken. I'm a psychiatrist with additional boarding in pain. Currently, I have the privilege of being the director of the Medical Pain Service at Duke University. My role currently is finding ways to successfully manage difficult pain patients and high utilizers within the pain sphere. What I'd like to share today are some of the ways that might actually make this type of work more satisfying and successful for you and your patients. We all know that the treatment of pain can be highly frustrating, and particularly when there are psychological comorbidities that occur. For every person, there are certain psychological manifestations that are particularly frustrating. I'm quite sure that all of you have had your share of these, and not just with pain patients, but even in other medical arenas, where somebody's been able to get under your skin really, really well. This even happens between staff at the hospital, let alone somebody who's in chronic pain. How we think about these events and how we construct our responses leads us to whether this will be a positive or a not so positive outcome. Today, I'll give you a few quick suggestions about how to walk out of these interactions feeling more satisfied than you have in the past. Let us start simply by getting a sense of what the pain patient may feel internally. Here's a classic definition of pain by the American Society of Anesthesiology. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage or both. Good definition. A little bit intellectual, but does have most of the talking points. However, this is still not how most pain patients actually experience pain. The patient is experiencing this in a very different way. The experience of pain is visceral, constant, intrusive. It is a message telling the patients constantly that their body is being damaged or harmed. There is no other disease like this. Cancer does not do this unless you actually have pain. Diabetes does not, hypertension does not, the heart disease does not, again, unless you actually have pain. Nothing but pain is so constant, intrusive, and persistent. It is also a disease that requires a constant change of behavior moment to moment. It does not permit you to have the normal function and action. Obviously, this commonly leads to great frustration on the patient's part and a sense of feeling out of control. For many people, the constant intrusion and level of pain even causes chronic underlying fight or flight symptoms with anxiety and agitation, commonly followed by depression. Another way of thinking about this is Psych 202 kind of way. It's how Maslow would consider this. Most of you have seen Maslow's hierarchy of needs. Take a look again and note that the base to Maslow's hierarchy is somatic integrity. This is needed before you can actually get to loving, belonging, self-esteem, and certainly self-actualization. So the pain patient's agenda, as it would be for all of us, is in any way possible to be able to regain somatic integrity. Hopefully, this will be through physical therapy or interventions or light exercise, but for some, those possibilities have long passed or not possible with the current physical or personality structure. So this patient is likely not going to be overly concerned about their relationship with you, other than what they can glean, so as to be able to get back to somatic integrity. This is not manipulation for addiction. This is manipulation for basic human needs, something we would all do. Please add to this the other common comorbidities such as depression or anxiety, suicidal thought, cognitive medication effects, all making up a very difficult comorbid soup. Over 50% of the pain population is clinically depressed, and so they will not have good motivation or concentration or energy. They have poor self-image and horrible sleep, and this is going to affect their compliance and presentation in the room substantially. They may feel to you to be too passive or undermotivated or malingering, when the reality is they're actually very depressed. Another common outcome is that some can be highly anxious. They may have low energy or high energy states leading to agitation and easy frustration. They also will have difficulties with concentration, be commonly irritable, with sleep disturbance and rumination. And now, once again, they can have difficulties with compliance, or they can have processing difficulties and not even understand all of what you're telling them, because they are too full already internally. So these people are like people that have a poor response to pain management, primarily because they have been inundated with a constant and unremitting message of somatic destruction. One of the more well-known outcomes of this comorbid soup is something called catastrophizing. It is likely the most studied of pain comorbidities and is essentially someone feeling that nothing worse could possibly happen than what is already happening and that will happen tomorrow. And it's just going to be that bad. That this event, this day, this pain, this moment, this doctor's appointment is just going horribly. This is actually most easily considered a subset of rumination, another common thing with pain patients. The best way to think about rumination is that it's like a blender labeled worry, sitting in someone's brain, always turned on. It makes no difference what you put into it. There will always be the same outcome. The assumption behind rumination is that if I think about it and worry about it enough, I will actually come up with a good solution. The reality is, it's just a blender. It makes no difference what you put in. It could be what is going to happen with my pills, or what is going to happen with this doctor's appointment, or does the doctor think I'm lying about medication, or what color the doctor's tie is. Anything you can imagine. It makes no difference. It is a process that takes up an enormous amount of space inside any pain patient's mind. The issue is that this impacts the pain patient's decision-making and planning, and can lead to greater anxiety, and in some it leads to impulsivity. I actually find impulsivity in pain patients to be one of the primary issues related to the misuse or the overuse of medications. When individuals are filled full of an anxious emotional state, it is easily driving them to some type of action. They have to somehow find a way to decrease the emotional stimulation that is going on inside. This can commonly be through the use of medications, the use of extra medications, the use of somebody else's medications. Inside that anxious ruminative state, impulsivity drives actions that they promise themselves they would never do, even following the best of intentions. Predicting that this is where the patient may be leaves us with an understanding that is hopefully able to lead us to better treatment options and makes them predictable. This person may need more aggressive psychiatric care, a change in antidepressants, an evaluation and treatment with a local psychologist for CBT. The thing to remember is that this is not someone who is trying to get one over on you. They are not trying to manipulate you, tell you what seems to be a truthful story in the moment in the office, and then come back to the next appointment reporting a whole set of other behaviors they promised they would never do. This is simply a pain patient having many of the same reactions any of us would.